Modern surgical procedures are becoming increasingly less invasive, with a subsequent reduction in the number of complications, in particular those caused by inflammation and infection, and reduction in the time required for post-operative rehabilitation. These three types of surgery will have their incision size reduced by around 70%, while retaining the same size implants. Bimanual microincision, phacoemulsification, has undergone major developments over the past 3 years, making it possible to reduce the size of the incision even further during cataract surgery. This is used increasingly as opposed to standard coaxial surgery. It seems to us that both of these techniques present advantages and disadvantages. The advantages of standard coaxial phacoemulsification are that this reference method is perfectly well coded and the instruments and machines are perfectly adapted to this technique. The disadvantages of this technique are essentially associated with an incision of between 2.8 millimeters and 3 millimeters, depending on the technique used, and concern both the possibility that this might induce astigmatism and the nature of the technique, made obsolete since the introduction of microincisions. Bimanual phacoemulsification presents specific disadvantages. Firstly, specific instruments are required, particularly for the rhexis, that may be performed either with a needle, a particularly difficult technique to learn, or using microforceps that are costly and difficult to maintain. Hydrodissection must be carried out with extreme care in order not to generate intraoperative hyperpressure. Fluidic balance is difficult to achieve. The only sure way is by highly leak-proof microincisions, but these carry the risk of causing corneal burns or deterioration of the natural imperviousness, requiring a suture. Irrigation aspiration of the mass is bimanual, requiring the learning of new skills. It is necessary to enlarge the corneal incision at the end of the operation in order to place the implant respecting the standards. Microincisions that are too large generate fewer complications at the site of the incision, but are responsible for intraoperative instability of the anterior chamber, which may cause serious complications. The surgery often takes longer, is more delicate, and requires modification of the usual surgical habits and an adaptation of the machine parameters in order to guarantee good intraoperative stability of the anterior chamber. We have kept the best of both worlds in the development of our technique. This reconciles the advantages of the two preceding techniques while eliminating their respective disadvantages. Since our technique does not require any modification of the usual surgical techniques of classic coaxial phacoemulsification, no costly instrument is required since the rhexis can be performed with the usual forceps. High ultrasound efficiency is due to the 21 probe. Phacoemulsification and implantation are through the same 2.2 millimeter incision with no enlarging. Intraoperative consumption of BSS is reduced. There is reduced risk of collapse and surges through the maintenance of the rate of flow of intraoperative infusion. The fluidic balance requires minimal adjustment of the machine parameters. The presence of a cover around the phacovacuum averts the risk of burns, respecting the incision architecture and ensuring a good seal at the end of surgery. Cleaning the capsule can be performed according to the surgeon's usual methods, either using the bimanual or monomanual technique. This technique can only be performed using an implant of specific materials in 25% hydrophilic acrylic, resulting in the polymerization of an acrylic hydrophobic monomer and an acrylic hydrophilic monomer at 38%. This co-polymerization gives this lens the pseudoplastic properties essential for its injection without damage through a 2.2 mm mini incision, using an injector and a special cartridge for anything from -10 to +35 diopter. This technique opens up new perspectives on small incision phacoemulsification. We think that it provides greater safety while being easier to master than bimanual microincision surgery. Our current development efforts, particularly in the area of the injection system, have already enabled us to perform surgery without complications, with no particular difficulties and without compromising the size and quality of the implant through corneal incisions from 1.8 to 2 mm.